everybody. Welcome to Ask the Anabolic Doc, starring Dr. Thomas O'Connor, brought to you by his websites, anabolicdoc.com and metabolicdoc.com, both of which you can get a copy of his new book, America on Steroids, A Time to Heal. Doctor, how are you, sir?
Excellent, Ron. Nice to see you another week. We just dodged another storm up here.
We did. My cohorts down at the Muscular Development offices, we're not so lucky. I believe 12 to 14 inches in that region of Long Island.
We got to get some spring flowers going, Ron.
I hate to say it, but better them than us, you know?
True.
Okay, so I got some great questions for you. You ready for them?
Yeah, it's a big, I can see this. Big week.
Big week. So, they're kind of lengthy. First one is from a man named No Donut. Maybe he doesn't eat donuts. I don't know. It says, I'm 55 years old, been bodybuilding since I was 19. Been on doctor-prescribed TRT last 6 years. 200 milligrams test cypionate per week and anastrozole 1 milligram per week. I'm 5'7", 210 pounds with a 34-inch waist. I donate whole blood every 2 to 3 months. I had a robotic mitral valve repair and a Cox-Maze ablation for AFib 8 years ago. Despite being on injectable Lovenox and oral warfarin and walking and doing light exercise every day after my surgery, I had a pulmonary embolism a week after surgery. The mitral valve repair left me with mild regurgitation, but the surgeon preferred that over doing a valve replacement. I've had no other blood clots or AFib ever since my surgery. I'm fine now, still kicking butt with the weights 4 times a week and doing 3 20-mile bike rides a week, and I feel great. It sounds like a man after your own heart, doctor.
Yeah, it does.
Current labs.
He's strength training and mountain biking. This is my guy.
God love him. Current labs: total cholesterol 172, HDL 46, LDL 107, triglycerides 91, hemoglobin 16.7, hematocrit 50, estradiol 19, PSA 1.2, total testosterone 1,151, free testosterone 258. Is that even right? Blood drawn on a Friday after Monday weekly injection. Previous echocardiograms have shown normal left ventricle cavity size and systolic function. Ejection fraction 65%. However, mild left ventricular hypertrophy is present. Today's blood pressure 138/90, pulse 75. My cardiologist is great, but he knows little about TRT or bodybuilding. My question is, given my history, labs, and age, is TRT safe at my dosage, and is it okay to lift intensely? I don't lift super heavy anymore. Instead, I do lots of drop sets, slow reps, etc. And is it okay to do long bike rides and carry all this muscle mass into my mid-50s and beyond? I love lifting and biking and don't want to stop. Also, forgot to mention, I'm on no cardiac or blood pressure meds, just daily baby aspirin. Cardiologist says I shouldn't do heavy leg presses, but everything else in the gym is okay. I won't hurt my valve. Repair done was an annular ring and sewn up flail posterior leaflet. Wow, that was a lot of medical jargon for one.
Wow. Well, I don't even know where to begin on this. So here it's a 50. So this is again, it's a guy in his 50s. You start living in your 50s, really, and if you feel great like this guy does, he has a great doctor. You want to go into your 70s and 80s so you don't have heart disease and you're short of breath and you don't feel good. So again, let's look at the details. Let's tease it out. Obviously, it's complicated stuff. The guy end up and medical things happen, Ron. So at the age, he has a mitral valve. He's an AFib. He pops an AFib, and he has a mitral valve repair. So there's an aortic valve. There's a mitral valve in people. There's a pulmonic valve. There's a tricuspid valve. The 2 common valves that are repaired commonly are aortic valve and the mitral valve. And Arnold Schwarzenegger had a bicuspid valve repair by Dr. DeBakey at Baylor Medical Institute in the 1980s, I believe, because Arnold Schwarzenegger had a congenital bicuspid valve. And that should be a tricuspid valve. So apparently Arnold was, believe it or not, on the sats. When he was super young, he didn't feel it. But then he got in his 30s, not old, and I believe 30s, maybe early 40s.
I mean, he was in his 30s in the 80s, so yeah.
Listen. So he was short of breath and again, I'm not breaking any HIPAA laws. He's not my opinion. This is well known.
Yeah.
Dr. DeBakey is an incredible, famous cardiothoracic surgeon of the world, and he was at Baylor. And Arnold had him. It was well known. There was even pictures of them together, and that was Arnold's cardiothoracic surgeon. Of course, Arnold gets the best. So Dr. DeBakey replaced his valve for a mitral valve. So this man had a mitral valve repair. Was it the same thing? Was it congenital? Was it because he had mitral valve regurg? It's beyond the scope of today.
Yeah.
But it is important, though, and this brings to mind, the steroid using guys, as much as I love and I don't hate, I try to bring across the world, as you get older, things are going to happen anyway. Why would you want to accelerate them? But that's okay.
Yeah.
So, this is a guy that he doesn't talk about steroids. He talks about at 19, he was bodybuilding, and then in 6 years from 55, so at 49, he's been on testosterone.
Yeah.
So, this dose is obviously basically a TT dose. Let me jump around a little bit. The dose, if you look down, the total testosterone is 151. The free is 258. That's picograms per mil,
yeah.
And that's going to be a little bit elevated. They're both a little bit elevated if you look for the top end normal reference ranges.
Yeah.
But is that the day after the injection? Is that the nadir? So the bottom line is, I'm not going to go into that, but if you look at the pharmacokinetic, the dynamics of intermuscular esters when they're injected, depending on who it is, how much, where it's injected, it goes up, right, Ron? It goes up.
Let me ask you a question, because I've often wondered this, and you're about to tell me, you're about to clear up my myth. Does it matter what the ester is? I mean, is there a huge difference? If I injected 200 milligrams of testosterone propionate right now and measured my testosterone levels in a couple hours versus the same amount of testosterone and anthate, would those have dramatically different results because they're longer and shorter esters?
So this is great bro science for all the broologists that are listening.
Yeah.
Broology all day long. It's just real. It's because if you can read a textbook, you can find out the pharmacodynamic, the kinetics that no one could argue the half-life of the drug. Cypionate or nanthate, 10 to 14 days. Propionate's less.
Yeah.
So if when you do inject these esters, though, if you inject it in your deltoid, in your glute, or your quad, over the course of days, though, depending on who, if you're massaging and you're using it, it actually can diffuse or absorb, into the blood system on a different time. And this is why I personalize everything for men. Mm-hmm. So it's very cool. So the answer to that question is within hours, not really, but within days they'll be in effect because propionate's short acting. Right. A nanthate and cypionate are basically biologically, as far as half-life's, identical. Yeah. So this guy's on a TRT dose. One thing everyone knows I just don't like is I don't like the inostrozole, because the problem with inostrozole, although it's a great drug to keep estrogen levels systemically down, it can. I told you I've had men with heart attacks just because they've had bad genetics for heart disease in the family. Their HDL is low normally, and then they used some of these drugs, including androgens, doses high, and then they throw the kicker in the end is they use inostrozole, and boy, any doctor knows who watches this stuff, inostrozole tanks your HDL. But you know what though, Ron? His HDL is 46. So you know what? So this is why genetics, right? There it is, Ron. This is why I never get bored, but I do the same thing every day, because every guy coming at me is going to be a different fingerprint. They're all different. So if you look at that. So you're I can't give medical advice, disclaimers everywhere. So, your stuff, you got a cardiologist right there. You're in a good place because you got a cardiologist. It's got to be a good doc for the heart, obviously. You had a mitral valve repair, then you popped into AFib. I don't see the timeline here. You popped in AFib. They ablated you. You after the procedure, the guy had a pulmonary embolism and he was put on Lovenox. And then Lovenox was given in the hospital short term, and then they converted him over to warfarin, which is Coumadin. We don't use those together, but that's okay though. So he went from Lovenox then on to Coumadin, and then he did that for X number of months, and he's off now, and then he's doing great. So that's a good example, Ron. Life is no joke. Like, when you have medical procedures, things happen. The guy had a clot in his lung. People die from this regularly, Ron.
The pulmonary embolism.
A PE, and that usually comes from a DVT. I don't know the story here, but I mean, you can imagine I can go on for 10 hours on this. I assume that PE came from his surgery. But now the risk on these valves is not PE, it's stroke, because it goes up into the carotid arteries, not the pulmonary veins. It doesn't go into the pulmonary vasculature. Those come from down below. So there's some interesting, and again, sir, no donut. It's a cool case. Obviously, he's like, oh, yeah, I had DVT, or he had something, and because after the surgery, and people are in the hospital system, the environment in the hospital, Ron, is a whole different environment than outside the hospital. That's why there's hospitalist only now. And I used to do this. I don't go in the hospital anymore. I had to give up on that. It was sad because I used to love going in. When I used to walk in the hospital, I'd be like, game on. I'm going in the hospital. It's a tough environment. I got to focus in here. Not that I don't focus outside, but it's a different, look at this, pulmonary embolism stuff. So the guy's got the heart. It seems like everything's great for the guy. His PSA is 1.2. I did last weekend I went to a whole review ground rounds with Yale Urology about prostate cancer and, of course, TRT and men's health issues. It was very, issues for men's sexual health and very interesting things about testicular cancer. So for young men and prostate cancer for older men. So things look good here. The guy, he's on no meds. I think the only thing he should check is probably, does he have heart? This is going to be also Evan C down below. We have a question. So we have there's something here. Can the guy, and I don't want to, again, if his cardiologist watch this, I want his cardiologist to say, thank you, doc, but I got this guy covered. Like, does this man, his vital signs, he's hypertensive. His blood pressure is 90. That's not to mention they dropped the top number down from 40 to 130. So he's hypertensive. He's got a little LVH. Does this guy, in addition to this, have a little plaque in the artery? Do a coronary artery calcium score, please, sir. And your numbers may look differently. We look at these numbers differently. Your LDL is nice. It's 107. But if you have plaque in the artery, you're going to want to drop that LDL way under 100, even under 70. So yes, you keep lifting forever. I keep lifting. I can't tell you the reason. Your doc doesn't want you to Valsalva because of your valve. I'm not a cardiothoracic surgeon. I'm not a cardiologist. So it's interesting. He doesn't want you to leg press, but everything else is okay. I'm not going to mince those words, and I'm not going to cut off the guy, and I'm not going to tell you what to do. But training, great, hard. Don't Valsalva. Train hard. The biking is great. Enjoy your life. Is TRT healthy? Is it safe? You're not coming off TRT at this point.
Yeah. So I think we need to explain the Valsalva. I don't think everyone would automatically know what that means. It's that basically holding your breath and your blood pressure builds up. Like, when as a power lifter, you have to do that.
That's all we do.
That's all you do to get the maximum weight because it creates so much intra-abdominal
pressure
and all that. But the leg press, you would do that on any heavy lift, not just a leg press.
So again, we're not, the guy, his cardiologist, and it's interesting. I saw a patient the other day. He had a bit. This is not a lifter. I have still a small percent of my practice are regular people. Yeah. And this man unfortunately had a heart attack, and that's why he came to me at the end of 2017, unfortunately. And I'm taking care of him now. Is with the cardiologist, and the cardiologist just put him back to work. And he gave him a 25-pound or less weight restriction. I mean, so it's interesting. So it's like the guy can't pick up a 26-pound box. I don't know. I mean, so it's just, the heart to me is so important, guys. It's so important, people, that if you're getting older, it's going to get damaged anyway. Look at this guy, mitral valve repairs. He pops into atrial fibrillation. I mean, otherwise his vessels are good. He's got a larging heart. Remember Ron, my LVH? Yeah. There you go. There's a guy, LVH, all day long, same stuff. So I would treat you, sir, very carefully with probably an ACE inhibitor for the LVH. Your doc would have to agree and be monitored, or lose weight, cut the sodium down. do the interval cardio, keep your blood pressure perfect. If you have plaque in the artery, you want to know, do a calcium score. If you have plaque in the artery, look, treat it with either a PCSK9 drug. Those are new drugs. I'm going to do more videos on that. Or take a statin. I'm on 20 milligrams a day of Crestor. I don't know, Ron. I mean,
well, you're gonna live to 110. So you're
I don't know, Ron. I'm living to 110. I'm going to do a video next week of me benching 405.
Okay.
I mean, they're not going to be fake plates either.
I don't think you would need fake plates, Doc.
But Ron, I mean, am I joking around though, Ron?
No.
Stop with the hate on all these different drugs we use, because if they work for you and you feel great, what's the better living through chemistry?
I don't think anyone's hating them necessarily.
Not you, Ron, but people get crazy against medicines, and it's just, all these medicines were derived from natural derivatives.
Right, plants mostly, right?
Well, so they're just like plants on steroids now.
Well, plant sterols, isn't that where they first figured out how to make steroids?
It's true, Ron.
Okay, let's get to a question from another esteemed Connecticut resident.
Boom.
This is Evan Centopani, who graced us with a question this week. Very smart guy. For a large portion of the population, less than ideal blood lipid values will result in the prescription and consequent consumption of cholesterol-lowering medications. Am I wrong, or is this kind of like shooting in the dark? From what I understand, a person having skewed HDL/LDL values does not necessarily mean they are at a heightened risk for heart disease, nor does picture-perfect blood work guarantee the individual won't have a heart attack. Ultimately, aren't we concerned with the formulation/buildup of arterial plaque, what tests, scans, etc. are out there to shed light on the actual state of a person's cardiovascular system? Is there one that is both accurate and cost-effective so that it can be performed on a routine basis, annually, for example? That's it.
Evan, unbelievable question. But it's kind of funny, though. Don't I say this every freaking week?
Yeah.
It's okay. Yeah. I'm just busting your balls. Okay, so Evan, this is the best question ever. It's just so straightforward. You're right. The Framingham data in which physicians use in the office to determine if you're going to have a heart attack in 10 years. It's called Framingham.
Can I tell you something? Can I interrupt? I met with a cardiologist the other day. I'm going to get my calcium score next week. You know what my chance of a heart attack in the next 10 years is?
Tell me.
2.6%.
Very interesting.
Yeah.
And so that's based on Framingham.
Right.
So we have to organize this data. So we look at men versus women. We look at your age. We look at smoking status, your waist circumference, your weight. We look BMI. We look at blood pressure. And all this is actually looked at to determine your LDL and what you do about it with a drug or not a drug. Mm-hmm. And we look at glucose status, pre-diabetes and diabetes, smoking status. What I'm trying to list them all in my brain here because I do it every day. Yeah. So, Evan and Ron, for you. So these are predictable models that are not 100%, Evan. It's true. There are men out there, and again, I just take care of men. Women come in a different venue from this. Women's heart disease has their own venue. This is men's heart life. Men have heart disease unknowingly and silent, and some of their labs, but Doc, I looked good on paper. That's basically quite uncommon. The more common piece is the guy that obviously probably doesn't look good on paper. He's hypertensive. He's got hyperlipidemia. His LDL's up. His HDL's down. Triglycerides are elevated. His sugar levels are up, pre-diabetes, or he's frankly diabetic. You put those things together, Ron?
Yeah.
That's ticking. That's a tick. That's going to be, that's predictable stuff. That's the Framingham. Mm-hmm. But there are people that, despite looking on paper, see, Doc, I'm still doing good. And then sooner or later in their 70s, maybe, hopefully never, but they end up having a heart attack or a stent. But it is, there are men that don't look so bad on paper, or they look good on paper, and they end up going to see my girlfriend, and they get a stent placed because she's an interventional cardiology nurse at St. Francis. And, So what you should do, Evan, is in addition to obviously being very smart like you are and keeping track of blood pressure, cholesterol numbers, and all these things that are certainly very important, coronary artery CAT scan calcium score. Cheap, effective, and safe. It will tell you, Evan, if you have zero plaque, and this is going to be calcified plaque where it's hardened already.
Yeah.
But if you're 40-something years old or even late 30s, if you're 20, it's useless. You know, unless you have a family history of hypercholesterolemia. Remember that, Ron?
Yeah.
But we're not going to do a calcium score for you at that point. We're going to go to an expert lipidologist, and you're going to have to be treated very carefully with those new medicines. Okay. So you want to do a coronary artery calcium score. It's cheap, effective, and you want to see if you have zero plaque at this time that's calcified, or if it's graded upward. I am turning over the world with this right now, Ron, with cardiology. I work with cardiologists. So every man who's 40 who has enough risk factors, which basically is 95% of men that come in here,
right,
on testosterone or not on testosterone, on steroids or not on steroids, they're just men. It's America. And I do two things for all these men. Calcium score, echocardiogram. The echocardiogram tells us if they have LVH, like the patient before we talked about. So hypertension and LVH. So that's when the septal wall starts to thicken. So if you can see, Evan, at this point of your life, if your left ventricle is thickening, in addition, if you have plaque in the artery, you could tell all this for a couple $100.
Wow.
You're done. And
so,
then,
let me ask you this, doctor. How often, it seems like, you know, the things like the plaque buildup and the LVH are such gradual processes that I can't see a doctor, you know, permitting you or giving you the green light to have a test like this done every year, would they?
Hold on. Next question. You get it done.
Yeah.
Depending on what the number is and depending on let's talk about the calcium score first.
Sure.
Depending on who you are, these are clinical pictures, Ron. That's why doctors need to come in and people need to reach out to doctors. You know, get over it. Go see a great doc. The younger doctors, by the way, you know, 30s up to 50s, 60s.
Yeah.
You know, some of these guys I'm hearing more stories that they're really cool now. They're really opening up and they're like, they're really trying, because I think they realize that they just got such a bad rap with all the saying no and pissing people off. So I'm finding doctors are better now. So go find that doctor or maybe that nurse practitioner. Really understand the stuff from my videos and all my education and reading what you read. And then you get a calcium score done. Depending on the calcium score, the experts tell me, you can't repeat that. You should not repeat that for 3 to 5 years.
Yeah. Okay.
So there's your answer. You treat you put the clinical picture together. The man, his blood pressure, his lipids, his cholesterol level, of course, his sugar level, his blood pressure, everything, all these pieces, and then you get a calcium score, and then you give a treatment program. This is what I do, and then that man's under your wing. And then the next piece is if the man's big, maybe you're hypertensive, maybe he's used testosterone or steroids, you want to see how his left ventricle size is. Like that man, not to mention the valves, but if you're short of breath and you're sucking wind, you're going to end up getting a stress test, echocardiograms. This is going to happen for everyone. So, but I like men that are just heavy and they're 40 and over, and if they have even non-optimal blood pressure, I get echoes and calcium scores, and you should see what I'm discovering very early. I could stabilize LVH. I could stabilize plaque in the artery. I could stabilize plaque in the artery from not turning into coronary artery disease and having a heart attack, and I can stabilize the left ventricle so it doesn't go dysfunctional into heart failure. I have a great video. It's a crazy video on my whiteboard where I discussed these mechanisms. So that's it. That's your answer, Evan.
Where can people see that video? It's your YouTube channel?
It's my YouTube channel. On Metabolic Doc, go to the YouTube channel, all the videos, and scroll down. We have, I don't know, hundreds of videos. I just signed a contract we got some great stuff. I got a new social media team coming. Hold on for about another week. Let's wait to see my next video.
Okay. Last question comes from Albertos. think he's in Spain. I'm not sure. Says, after 20 years of training natural, I just did my first cycle. I was so afraid that I only took 10 milligrams D-ball for 1 month just to test the waters. Still, I noticed increased fullness, some strength gain, a little water retention in the belly. I gained 1.2 kilograms of weight and, strangely, vascularity and increased appetite. I have no PCT in hand, just some liver protection, ZMA, and fish oils. I will see how much I'll retain of it. I plan on doing a proper 20 milligrams 6-week D-ball cycle in the summer, but where I live I have no access to any PCT, but I can do regular blood tests rather cheap. Any particular side effects I should be worrying about during or after this cycle? So I guess he just wants to be safe because he's an older guy.
I kind of want to ask you this question, Ron.
Sure, ask me.
I mean, this is like, I don't know, guy with D-ball. It's interesting. D-ball is the old school, oral Dynaball. It's he got vascular versus he should have got puffy and fat. What do you think about this, Ron? What do you think of this question?
Well, yeah, I don't think he had D-ball because with D-ball you do get water bloat.
Yeah.
A lot of people. 20 milligrams is a very conservative dose for a male, of any size. So I'm surprised that the 10 milligrams he did anything for him. But I guess if he's been lifetime natural, any exogenous testosterone synthetic is going to have some good results for him. I would be concerned, as you've spoken about many times. Anytime people that have been natural for many years decide they're going to do a cycle, inevitably a lot of them want to just do orals.
Yeah.
Because they have this phobia of needles, or they have it backwards. They think injections are going to be more dangerous.
So funny.
And I tell people who've already made their minds up. I'm not going to talk anyone into using steroids, but if they've already decided I'm going to use steroids, I said, please, if you're going to do a cycle, and you're going to just do one drug, just get some tests and do a shot twice a week. It's much safer than, they're saying, well, I'm going to get some Anadrol, I'm going to do 50 milligrams, or I'm going to get some D-ball, I'm going to do 50 or 75 milligrams of this every day. I said, dude, if you're going to be on that for 12 to 16 weeks, your liver values are going to be insane. Your eyes are going to turn yellow. I mean, your liver's not going to be happy.
That's true.
But,
remember I told you the guy, so a little side note, I had a guy from the Arab Emirates come in, and he was I call him the Sheik, and he went down to Hopkins. He was a Sheik. He was living on Turinabol. Remember my story, my Turinabol story?
Yeah.
I tell the same stories over and over. And the guy was so scared of injectables. He did, I don't know, like 100 milligrams a day of Turinabol, which is like the dry D-ball, right?
Right.
And he did it. And a lot of people do that. It's a great old steroid that people really liked, I guess, and women like it. And he did it, but he did it for 18 months, Ron. Wow. Never came off. And he did get huge liver cysts, this big and he ended up getting, sent with a private jet to John Hopkins, and they removed parts of his liver, and he did well.
Oof.
They weren't cancerous. They were just huge liver, blood filled. And
so I'm sorry. Do they have to go in there and they take the cysts, or they actually
remove? So the liver's set up in all these segments. Okay. It's very amazing. And the surgeons, these are general surgeons, but obviously some of these experts just specialize more in liver versus intestinals, colorectal. So they removed. They know exactly how to remove whatever segment of that liver needs to be removed, and they remove it cautiously. And he was in the ICU, in the surgical ICU they called when he was in the ICU, and he was transferred out of the ICU to the floor after a few days. Yeah. He did very well. They transferred him home. He flew up to Brainerd, took a limousine in, and I met with him. It was really cool. And I didn't have any lab. We just had discharge summary from the hospital. And he was with an entourage of people and stuff. Very cool guy, very 35, something like that. Very good looking guy, and thin, very small. Not very heavy. And I explained to him, he wasn't thinking about his sex at that time. He said, I'm scared, Doc, and I'm amazed, and thank you so much, for your. He praised the Americans, which was really nice to hear, and because he did go from there to Hopkins. He could have went to England or somewhere else, or China, or his own country. They have great doctors, I guess. But he came here, and then we took care of him. the guys at Hopkins, and then he came to see me when he was going back, and I said, look, let's let you cool down for a while. Let's repeat your labs and see how your testosterone levels are, and maybe we could put you on some testosterone if you've suppressed those, because he didn't do PCT. He just stayed on Turinabol for a couple of years.
Yeah, wow.
So I know, it's amazing. So that's my story. So this guy, what can I possibly say, Ron? The guy's taking oral steroids. You probably don't even need PCT. I bet you. I hear so many more guys. Obviously, I'm taking like one new patient a day. I'm exhausted, but it's really fun. I'm going to work in the next 6 months. I'm working on getting a new associate doctor to work under me for Florida for sure, because I'm just going to be overloading sooner. I'm already there.
Yeah.
So I'm training and sharing what I've learned with the world like this. But, a lot of guys are coming in, Ron, and I see they do Anavar, just Anavar.
Yeah.
And a lot of them have horrible sexual problems on Anavar alone.
Wow.
Yeah, I'm kind of so far removed. Most guys do test as the base. Let's just talk about what guys do. Like you said, they just live on test, on and off test, Cypionate or Xanthate, Propionate or Sustanon 250, and they just do test, and then they add the other injectables, or they add some orals if they're powerlifting, or they're just trying to have fun. And I mean, if you're going, let's just call it what it is, Ron. If you're going into the pro level of this sport for what it is, Ron, it is what it is, man. Mm-hmm. I mean, this is a whole different life, Ron, and you know that.
Yeah.
And that's just what it is. And those guys have great genetics, and those guys are they're just doing, that's what life, that's just what it is, Ron.
Right.
So, but this guy's not doing that. This guy's playing around, going to have a great summer, and he's going to do some D-ball, and he wants some, PCT for a little D-ball, I would tell you, sir, I have to tell you the same stuff. Please don't do it. If you're going to do it, the risks, you're going to, mainly you could shut your brain off. Do I see guys shut off from a little D-ball cycle or a little Anavar cycle? No, not really. Some guys, but I see they definitely go through a period where they may do some type of PCT like Clomid, HCG, some tamoxifen. They do the combination. They do what they think. They read the stuff online, and and then after a couple of weeks they stop it, and no one tells me I felt great. I just don't hear that. Maybe those are the guys. I guess guys who come to me, by definition, don't feel great.
Right.
So I guess that's why they come and they see. So therefore, guys can feel great, but I'm never going to see them.
Yeah.
Until they feel bad. So you don't. There's no rules on PCT. You should not do the drugs. If you do the drugs, you should do as least as possible. I agree with Ron. Like oral steroids. But then again, if you're going to do testosterone and you do it for a short period, when you come off, your brain's probably going to go, oh,
yeah.
Because you're going to feel. And then, do you want that? Do you say, I got enough, I did it, I'm great, game on, I'm going to do time for a tennis match? I don't know. Did you bite the bullet? Are you going cold turkey? Are you white knuckling? Do you need to do that? Are you going to go back on again? It's just, Ron, these are discussions. We need town hall meetings. Come on, Ron, don't we?
Town hall meeting.
Ron, Anabolic Doc goes town hall.
I'd go to that meeting.
Ron and the Anabolic Doc town hall with Trump now. I don't know. What do you want to do?
I'd like to see the irate citizens stand up and
Ron,
complain about the trash removal, and we got to tell them that's tomorrow.
So, night. Sir, I can't obviously answer and tell you what PCT you should do or not do, but I think we answered the question pretty clearly. It's an interesting question. But with that said, we have some good news in the world right now. I've been contacted again over this last week by more VIPs in the political world and in America, outside America, that are really giving, it's about my book. Okay. And they're really say, we're awakening. We have some good, I don't want to say what it is yet, but there's some journalists coming in, and they're really saying, wow, Dr. O'Connor, like your book, America on Steroids, we didn't realize, like, is it really not the baseball players?
Well, you mean they thought those were the only people using steroids? In America?
Ron.
Yeah.
And I don't know. I mean, the elephant in the room. At least they're acknowledging the elephant in the room. They're doing sign language to him now. But doctors are cool.
Yeah.
I had some patients are joining. They have doctors. I don't work alone, right? I don't work alone.
Yeah.
So like, this last week, we got guys every day coming in, and it's like a lot more PCP guy, primary care doctors, PCP, PCT, PCP. It's like, I get crazy.
Yeah.
Primary care doctors, PCPs. They're younger, they're cooler. They're just being like, yeah, man, you're using steroids. I just don't know what to do, sir. So, yeah, the Anabolic Doc, I guess, yeah, it looks pretty cool. Like, go see him. It's just like,
Yeah, I want to just interject because the cardiologist I met with a few days ago at one of the Beth Israel Deaconess hospitals here in Boston, he couldn't have been more than 35 years old.
awesome.
And at first I looked at him, I was like, because I have that bias. Then again, if I saw a doctor that was too old, I'd do the same thing. I'm like, he's probably not up on all the current things. But this guy, I'm like, aren't you a little bit, I wanted to call him Doogie Howser or something.
Oh, that's great.
I'm sure that's like the worst insult you can give to a young doctor.
That's okay.
But,
He likes it.
He was really, I don't want to say hip, but he was really non-judgmental. When I talked about the steroid use and everything, he didn't flinch. He didn't look shocked or jaw didn't drop. And he just said, okay, he's typing away. He's like, okay. And he just would ask more questions. And
That's it.
He's
Ron,
I think
Ron, we did it. I think we're doing it.
Yeah. So times are changing for the better. So I think there's going to come a time very soon where, gear users, former and current, won't be afraid to be honest and upfront with their doctors and disclose everything so that they can be treated right. Because I still think that's a major stumbling block in guys getting the treatment they need is they're afraid to tell their doctors, I'm on steroids or I use steroids because they think their doctor's going to judge them or think they're a bad person.
Ron, right now, 100% still the problem. There's still that impediment and that barrier. But here's a week where I have good stories. You have a good personal story. I'm so happy that you went to the cardiologist, Ron. That's awesome.
Yeah. Calcium score next week. I'm going to maybe we'll go over the results on the show.
Oh, Ron.
See what happens.
Good stuff, Ron.
No, probably not if it's too bad, but I think I'll be okay. Yeah.
Here we are, Ron. I'm proud of you, buddy.
Well, it was your constant nagging. Usually we stop recording and you nag me to do it. So.
That took some guts, though, Ron. It took some guts.
I want to be around a while. I don't know about 110, but maybe 106, 107.
I love it.
Yeah. After that, I don't know. We'll see. We'll see how it goes. All right. Any more news to share?
I think that's it. I think it's a good big week, Ron. And I want to get more questions for guys. Like how do we get more questions out there? I think questions are good across the board.
I think I need to stop waiting until the day before we record episodes to ask for questions. Maybe I should just leave. I'm going to leave a thread up all the time.
Because I think guys, and I look at this, Ron. Look at these. What's interesting, Ron? They're mainly focused around cardiovascular disease and steroids.
Right. Which is exactly what you're here for.
That's my deal. That's my deal.
That's your thing. That's what you know. That's your 9 to 5, as you say. So cool. All right.
Well, Ron.
That'll wrap up another one. So thanks, everybody, for watching. And remember to check out the doctor's websites, anabolicdoc.com, metabolicdoc.com, and, of course, pick up a copy of America on Steroids, A Time to Heal. You too may have an arm like that if you're lucky. All right. Dr. O'Connor, thank you so much. And thanks, everyone, for watching Ask the Anabolic Doc.